All right, guys. So after a heat stroke, of course, hallucinogens. So I'm Dan. So first off, we're going to talk about what are the drugs that are commonly used, how do we treat them, and what's happening in the future, because those little street chemists are making some stuff that you would not believe. So first of all, I debated about putting this in there. I haven't tried any of these things. There are people in this room that certainly have.
Seriously, you haven't?
I have not. So, believe it or not, I know, and that's why I bring this up, is I actually grew up really straight edge, all right? For those of you that know what that means, you're laughing, and that's fine. But it means I had a pretty boring and very straightforward childhood of not doing anything. I didn't drink alcohol until I was 21, never used any street drugs whatsoever, okay? So I say take that with a grain of salt that you have people that use these drugs that you know. You may personally have done them, but you have patients that have used these things, and you should talk to them to find out what they're going through, because that helps you actually take better care of them. I know that's a little touchy-feely, but I don't know what cocaine feels like. That guy that's over there in another room does, okay? So if you don't know how people are actually using drugs, you won't know what they're taking. And the fact that people are taking pills and they don't know what they are, or the fact that people are hot railing meth, and the fact that many people don't know what hot railing meth means is a problem, because you're taking care of these people and you don't know what the problems are if you don't know how they're actually ingesting these things, okay? So what are the hallucinogens? So this is the relative harm caused by drugs, okay? So if you notice, far and away, the two things that kill Americans are the legal things, actually, okay? So alcohol causes you to hurt other people largely, but it also damages your own liver. And then also the tobacco, okay, where lots of people are dying from lung cancer and whatnot. Of course, there's some heavy hitters like heroin and crack cocaine and meth. Those are known problems, okay? Marijuana, this is basically, they asked a bunch of British experts, like, hey, what drug do you think is hurting a lot of other folks? And they actually put marijuana very high, higher than anyone else did, actually, okay? So that's actually surprising. And then if you look down here, these are a lot of the hallucinogens are down here, okay? Turns out if you take LSD, it's unlikely that you're actually going to go hurt anybody. You might have a really bad evening, but it's unlikely that you're going to hurt people in the same way that someone that is drunk driving will, okay? This also has to do with how many people are taking these things. There's not a whole lot of people that are out there taking khat in this country. They're just not. So it's not surprising that there aren't a lot of those folks, but there are a whole bunch of people drinking. And so a little bit of this, it kind of hides the fact that a lot of these substances are exceptionally dangerous. It's just that people aren't taking them as commonly because it's hard to get them, okay? This is basically a Lancet article. There's a graph that shows basically how much dependence things are caused by and then what amount of physical harm happens, okay? And you'll see that the farther up here you get, the worse you want to be. You don't want to be in the top right of this graph, okay? Because it means that you both aren't able to stop taking this medicine, or I shouldn't say medicine, this drug, but it also means that it's more likely to hurt you, okay? A lot of hallucinogens come down in this way, which is one of the reasons that many people are using them and you don't necessarily know it. Because there's a lot of people smoking pot in Augusta. Most of them don't come to the emergency department. So let's talk about marijuana. So it's most commonly abused psychoactive substance. We often talk about THC like that's all there is in marijuana. It's not. There's a lot of different ways that people take it. So everyone knows that you can smoke it, but increasingly people are vaporing it. They actually call this stealth vaping. So don't assume that just because someone is using a vaporized e-cigarette that there's necessarily nicotine or tobacco-related products in that. There are actually ways that people are diluting this stuff down with organic solvents to make it so that they can vape. And unfortunately, or fortunately, depending on your perspective, it doesn't really smell like marijuana because a lot of the stuff that's in there, if they're using synthetic chemicals, don't have that classic pot odor to it, okay? So you wouldn't really know, especially if they have, as is common, flavors on it, okay? So if you see someone and they're acting really weird and they're using one of those e-cigarettes, it may not be the case that they're actually using it for nicotine, okay? And then, of course, ingesting, because it turns out that a lot of the oils that you can get from this plant can be put in butter, and that's why they always have baked goods that are kind of fatty, okay? You're less likely, to have like kale spread or something like that that's made out of this, as you are like cookies and brownies because they have lots of butter. And that has its own problems, because it turns out your average pothead knows exactly what happens if they smoke a joint of certain size. You have no idea how much of this stuff is in something if you eat, say, a brownie or a cookie. okay? And they're actually running into this problem where they have made it legal to buy it recreationally. Because people think when you buy a cookie at Subway, they want me to eat the whole cookie, okay? They don't assume, there's lots of weird things about FDA labeling of, oh, you buy a cookie, that's 5 servings. And that's how they get to like, oh, there's only 8 grams of fat per serving. It's garbage. You're eating the whole cookie. Like no one buys a cookie and eats half of it. I don't trust that guy, okay? But the problem is a lot of these things have enough THC in them to where they're selling a cookie and it's supposed to be like enough to make 8 people high. So it's a real problem because then people eat the whole cookie. And if you ingest it, there's actually a delayed effect, okay? So if you smoke it, it happens fairly quickly within the next 10 to 15 minutes. If you ingest it, sometimes the effect is delayed for 1 or 2 hours. So what happens? People buy plane tickets to Colorado. They go out there, they buy a pot brownie, okay? And they buy a big one because, hey, we got on a plane to get here. And they start eating that pot brownie and nothing happens. And so they eat some more, nothing happens. They eat some more, nothing happens. And then an hour and a half later, they get higher than anyone should ever be. And it's really, really dangerous for them because that almost never ends well, okay? And it's because that dose-related response that people have found over time of, I smoke a joint and this is what happens, isn't there because of that time lag. So what are the problems with marijuana? They're actually highly debated, okay? So it's associated with early psychosis. A lot of these folks may have been at high risk for psychosis anyway. So we don't know. It turns out that if you smoke pot, you're more likely to be diagnosed with things like schizophrenia earlier in life. That is established. The question is, were those same folks the people that were at high risk anyway? Okay, and that we don't know. We just don't. It's association, not causation, okay? It definitely impairs your short-term cognition over the course of 1 to 2 weeks, somewhere in that area, okay? So pot does make you dumb. It's not clear if pot makes you dumb permanently. They just don't know, okay? And partially because they don't have long-term studies. It's certainly the case that if you smoke a lot of weed, you're probably not going to go hit the textbooks particularly hard, and so that might be part of why you're dumb. But even on cognitive assessments, you're actually slower. The same is the case for alcohol. I'm sure no one in this room has ever drank too much alcohol, but have you noticed in like the next week or two, like you're not quite as sharp as you were. So it's not just a problem that if you abuse alcohol that you're a problem if you show up drunk to a shift. If you're abusing alcohol, you're really not as good of a clinician as you could be for the next few weeks as your body tries to recover from that. There's the coming up like cyclic vomiting syndrome. Y'all have read Larry Melick's emails. I'm not going to belabor that more. It's also unclear if it's associated with lung cancer. There don't seem to have as much evidence that if you smoke pot, you're at higher risk than people that don't smoke cigarettes. But there is some emerging data that if you smoke both pot and cigarettes, you have a higher risk of lung cancer than if you just smoke cigarettes. That's weak associative data because the people that do that tend to smoke a lot more in general. But it is a little bit of a thing to make you pause that it may not be quite as healthy. And one of the major concerns is the risk of DUI for people that smoke pot. That if they're under the influence of this, it's harder to test this at the roadside than, say, a breathalyzer. And this is actually one of the biggest things that law enforcement brings up about how it's dangerous, okay? It turns out that people that are on marijuana tend to drive slower, but their reaction times are really, really slow. So they tend not to get into the catastrophic accidents that other people do, but they're still crashing a lot, and it certainly isn't safe. It's probably more or less on the same layer of risk as driving drunk, okay? That goes back and forth about which is worse. Should someone be stoned or drunk while driving? The answer is obviously none of the above. So, moving on to LSD. So, lysergic acid diethylamide, for those of you who haven't sold out to Big Pharma. No. No, it's just LSD. It's acid, okay? So, the problem with this is that it has a heavy sympathomimetic component to it as well. People often come in tachycardic. They're kind of amped up as well. This drug is actually associated with coma and respiratory arrest. It's not clear why, exactly what that is. But it's very easy to overdose in huge amounts because the way that people take this drug. We'll talk about that more. It can last up to 12 hours on a single dose. The well-described flashback phenomenon of months to even years later, people having recurrent hallucinations is real. It's just a question of how common that is. It doesn't appear to be very common, but it's certainly the case. And it is very terrifying that it's possible for you to take something and then even decades later have unwanted flashbacks of issues. So blotter paper, okay? This is how most people are taking LSD. It turns out that it's often in like a liquid form, but no one is out there with like teardroppers. They often put it on stamps or stamp-like things, okay? And these stamps are often heavily marketed because it turns out that drug dealers are excellent at marketing. And so they put crazy photos and stuff on them. People either put this under the tongue and let it dissolve and spit out the paper, or just chew up the paper. They do it either way. People debate about whether or not you should eat the paper. I had a very enjoyable Google search. But that's what you're looking for, okay? So if you see some stamps, you're not really sure what they are, that's often the case. Sometimes people will put them on like little candy button looking things as well, is also a common thing. So they almost look like, the candy buttons that come in big sheets. Some people do it in that way as well. But normally it's on the stamps made of blotter paper. So what about shrooms? So psilocybin is the active ingredient for this. A lot of people call them magic mushrooms or shrooms, okay? This is the type of mushroom that you're looking for, not this, okay? So a lot of the, this is what I saw in Super Mario Brothers, are not the shrooms that people are talking about. Probably the most dangerous part of this particular drug is people picking the wrong mushrooms. That is probably the biggest harm, is because there's a lot of mushrooms that will straight up kill you dead. And there's a lot of people that think that they can identify the differences between the shrooms, and they get the wrong ones and end up with liver failure. Because it's not just the big ones that we talk about, but quite a few. And it's a real tragedy. It's very variable for the potency because different mushrooms have different amounts, and it's very hard to figure out what the dose is of this particular drug. Seizures and hyperthermia happen, but they're not that common. And it often induces a feeling of hyper-religiosity, okay? So people feel very, very religious or spiritual or zen, okay? So there's very few randomized controlled trials of this is what we happen when we randomly gave people this drug versus that. But this one is just too much fun to avoid. So this, this study actually randomized people to whether they got basically psilocybin, so they basically gave them shrooms or not, and then find out what happened to them, okay? So it was actually double-blinded at Johns Hopkins, of all places. And, you know this one? Yeah, it is crazy that the IRB was asleep at the wheel for this one. So they took 36 people that to get into the study, you couldn't have used drugs before, all right? Yeah, apparently, yeah. And 1/3 of them described this as the most spiritual event of their life. And 79% of them reported well-being 2 months later, okay? There were about 1/4 of them or so that had intense paranoia and had really bad experiences. And most of those were managed by what they called reassurance, which I think is paper form of saying, chill out, Bob, chill out, which I think is pretty much what they did. So believe it or not, there's actually emerging research that people are wanting to use this for depression in a controlled setting. And it is obviously very problematic to study. But that is coming in the future. So MDMA, or ecstasy, okay? Methylene dioxymethamphetamine. The only part of that you need to remember is the amphetamine part, because we often forget about that. So this is a cousin of meth. Okay, it's different, and the effects on the actual person are a lot different. But remember that you have a lot of sympathomimetic stuff. Bruxism is really common, where people like grind their teeth and so forth. And one of the biggest dangers that will actually acutely present to the emergency department is the risk of hyponatremia and seizures related to that. That happens a lot. We'll talk about that more in a second. There's long-term damage that is apparent on MRI scans, where people that do a lot of ecstasy, they tend to have like holes in their brain later on functional MRI scans. We honestly just don't know what happens if people take this for a long period of time, but it's probably not good. So how many of you guys have ever seen someone at a club that had like a pacifier like attached on a string around their neck? Like, these people are out there, okay? And the reason those people are out there is that they're on ecstasy. I just say this because I've actually seen people that had, like raverware kind of stuff come into the emergency department. And so what happens is these people have an oral fixation and they want to have something in their mouth. There's no better way to put it than that. I tried a few different ways. That's just how it is. And so, believe it or not, there are adults, and it's particularly hilarious if you Google pictures of men with pacifiers at a club, but they just have something in their mouth. And that's because they have bruxism and dry mouth. So what do they start doing? They drink a lot of liquids that have lots of free water in it, okay? Sometimes it's just pure water, like bottled water. Sometimes it's other hypotonic solutions, like alcohol. So they'll just drink beer with it or something like that. But a lot of the stuff they have doesn't have adequate salt. So they get hyponatremia. And then once you get enough hyponatremia, you end up having a seizure. It's also likely the case that with these amphetamines that you're lowering your seizure threshold as well because of that. So you end up with a problem. So this is Molly Shannon, not the Molly that's referred to as Molly. It's often described as a pure form of MDA. This is highly questionable. So the term Molly comes from molecule, and that cule part just isn't very cool, so they just made it Molly. And it's basically a powder form of MDMA. That's if what the guy selling you is not lying to you, okay? Because it turns out this is relatively expensive to make. And drug dealers, while they're great at marketing, they're also pretty good at economics. And it turns out if you can substitute something that's not an expensive thing for something, you put it in instead and sell it as Molly, then you're going to do that, because it turns out they can't go to the Better Business Bureau and be like, oh, he sold me bad Molly. Like, they just can't do that. So often other stuff gets substituted, including things that are like bath salts and other stuff, and sold as Molly, okay? So while it is true that this is a fairly pure form of MDMA if it's sold as Molly, it's often the case that what's actually bought on the street is not actually MDMA. These are also incredibly concentrated, so it's much harder dosing. It's in a powder form as opposed to the standard pills that a lot of people take for X. And so because of that, it's really, really hard for people to figure out how much they're dosing, and it often leads to incredibly high overdoses. So a related thing to hallucinogens is dissociatives. And if you think about it, the difference between a hallucinogen actually causing you to see something that's not there and a dissociative distorting your reality to where you're interpreting things in a weird way is a very fine line. It doesn't separate very well. So whether you take acid, then you see a bunny that walks across the room, or if you take ketamine and you're so like gorped out of your mind that you misinterpret, Frank for that bunny, then it's kind of the same effect. And so dissociatives are a closely related group of compounds. Ketamine's the classic for this. A lot of people are often dismayed that people abuse ketamine as a street drug, saying like, oh, if you just want to fall asleep, what are you doing? Like, why would you do that? Most of the people that are abusing this for its street drug purposes are not actually taking a full dissociative dose. They're finding what's called the K-hole, which is where they're basically a little bit more than your analgesic dose. It's in that range, but not to where you would fully dissociate and just fall asleep. Okay, so that's what a lot of people are actually doing. And there's actually a real global emerging problem with ketamine. It's an old drug that's becoming new again, so much so that in China, it's so popular that China recently tried to criminalize it and put it on the banned drug list across the entire world, despite it also being on the WHO list of essential drugs. So it was nearly a drug that was both forbidden to be traded globally, as well as a drug that was required to be traded globally at the same time. That nearly happened a few months ago. So PCP, we don't see a lot of this locally, which is a really good thing. It's often smoked or snorted. This is going to be much closer to meth in some ways, but it's got a particularly nasty combination. So often when you're doing vignettes, it's the guy that's like hulking out, and that's PCP. That these people are not pleasantly dissociated. They are crazy and insane, and they're often really strong. Now, why is it? Because this isn't an anabolic steroid. It doesn't actually make you stronger. Well, it turns out that it's got three things that are going on at the same time. It dissociates you, so you're not really sure what's going on around you, okay? It causes anesthesia, okay? So if I get tased by a cop, I'm going to go to the ground and be like, yes, sir, whatever you want to do is fine. I'm done being tased. But it turns out if you don't have proper interpretation of your pain, then yeah, even if you break your arm, I'm not out of the fight yet. You break my arm, I'm done fighting. Like, it's time to talk. Like, all right? But if you break a guy on PCP's arm, he's like, you know what? I didn't really feel that much. I'm going to just flail my limb at you. And that's what they'll do, okay? And so you end up with these incredible things where, like 15 cops had to pile on top of a guy and he's still like emerging from the mass. And then it also causes paranoia, okay? So as you can imagine, if you have someone that is confused by reality, seeing things that aren't there because they're partially dissociated, they can't feel pain, so that if they get into a bar fight and someone normally delivers what would be able to enough to where a sane person says, you know what, my jaw is broken, I think I'm done with this fist fight, and then you also make them paranoid, it leads to a real problem. And so that's why all those vignettes always use PCP. The problem is that now with a lot of the street chemicals, even if they're not actually taking PCP, they're taking things that are kind of the cousin of PCP. And that often cause these things, particularly when you mix them. So this like terrible triad of I'm confused about what's going on, I can't feel pain as much, and I'm paranoid is actually not just a PCP thing, but a lot of the things that the street chemists are making now. So peyote. So peyote is never going to be a mainstream drug of abuse. And the reason is that it makes people puke. And it turns out people don't like to puke. So they collect these cactus flowers. You can dry them out, make buttons. But it's so extremely bitter that you have to, nobody really does this stuff. I've never seen a local case of someone saying that they did peyote. Maybe the vegans are going to get into it or something. They're not to be trusted anyway. But, they get what they deserve, okay? They get what they deserve. All right? So how do you treat? First is benzos, all right? We're going to talk about why. Next, environmental control, okay? These people are tripping. Please don't put them in the middle of your loud, exciting, bright emergency department. You need to reduce stimuli. And then the last thing is electrolyte management, which is the thing most likely to actually kill them as long as their vitals are okay. So, do not fall into the trap of giving B52s to these folks. And the reason is that Haldol does nothing for them, okay? What they need is benzos, and more benzos, okay? You can give this in a lot of ways, okay? If you've got the walking well who says, look, this is not cool. They often get brought in by their buddy. I've seen this a few times over at Trinity in particular. For whatever reason, they just don't come to MCG with this stuff. But at Trinity, some guy had a bad trip or whatever, and he comes in and he looks fine. He's okay. You don't even necessarily need to put an IV in him. It's okay to give a couple milligrams of PO Ativan, okay? That's okay. Just take the edge off, because it turns out coming at them with an IV and the 15 minutes that it takes to get that started is not always ideal. It can be a lot quicker just to give them some oral Ativan, okay? If they're a little bit sicker, IV or IM Ativan or Versed is actually probably a very reasonable thing. Some of these people are so agitated that it's actually really hard to get an IV on them. They're often younger, so they got better veins most of the time if they're not also an IV drug abuser. But remember the IM route as well, okay? If I was going IM, I'd probably go with Versed, something on the order of 10 milligrams for a full-size adult. If you're using IM Ativan, anywhere between 2 and 4 milligrams is probably quite safe. And then immediately establish an IV as soon as you can. Haldol has a lot of anticholinergic properties, which is common with particularly some of these sympathomimetic things, and it can increase their heart rates even further. So they often come in with heart rates in the 140s and 150s, and then you're giving them something that's going to raise that even higher. It's just generally a bad idea and doesn't really help the underlying problem, okay? One other thing here is ketamine may actually be a potential pharmacologic thing here. If someone came in on a PCP, they're just thrashing everywhere, what you might end up doing is you're stuck between two choices, okay? Just give them Ativan and hope for the best is probably not enough. They're a danger to themselves and others, and the 15 minutes or so that it's going to take for an IM dose of a benzodiazepine to really get them calm is just too long, okay? They're going to hurt themselves and a whole bunch of staff before you get there. So one idea is to use a dissociative dose of ketamine to put them down, let them chill out, and then you can establish IV access, give them plenty of benzos, and then prevent an emergency reaction by doing that. This is a little bit risky, and the reason that it is risky is that ketamine has a known problem with emergency reactions. They are essentially already going through an emergency reaction right now, so you're already behind, okay? But that's actually what I would do. If there was a guy who's strapped to a gurney, he's in leathers or whatever, and he's just thrashing around, he's going to hurt himself or somebody else, and we can't do anything, I will give him IM ketamine, enough to dissociate him, which is often on the order of 4 mg per kilo, get an IV access, get fluids, get labs, and then start heavy benzos while that person is down, okay? The whole time that I would do that, I would be ready to intubate, which is really your only other option. That's the traditional option of, oh, this guy is just all over the place, let's just tube him, okay? And I would submit to you that even though ketamine is related to these other things, you can get access, get control, and give them enough medicines to manage your patient properly that is likely safer than the idea that sucks is your treatment of choice. Because that's really your other option, is to basically come at them with IM, etomidate, and sucks, which is not ideal if you can avoid intubating these people. Next up, environment control, really crucial, okay? These folks are responding to stimuli in their environment. There is no louder, more bright, noisy place in the world in the middle of an emergency department. That's why your stethoscope will never pick up that 1 out of 6 systolic murmur. It's the same reason these people lose their mind when they get here, okay? So there are a few things that would be worse than putting them in the back of an ambulance that is moving with lights and sirens going on and then dropping them off in the middle of a loud emergency department. This is not what a paranoid person wants, okay? So what do? You try to make this as comforting an environment as possible. You dim the lights, you put them in a room without a lot of distracting stuff in it like A1, and then you try to let them chill, okay, to give those medicines some time to work. Electrolytes. These are the ways that people will really die from this, okay? Most of the time, these folks are young enough to where they're not really going to get hurt too much from having a heart rate of 150, because it's increasingly a problem. The most rapidly growing group of people that are using drugs are actually the elderly, believe it or not the young people who are actually using fewer drugs than in recent decades. But electrolyte abnormalities are one thing that can put these people out, okay? Hyponatremia is probably the most common. That's going to be associated with ecstasy, okay? If you don't have access to point-of-care chemistry labs and someone comes in seizing and you think that they've been at a club or something like that, then it would be very reasonable to treat with a small dose of hot salts. I think that 3% normal saline would be justified empirically, because the odds of them being hypernatremic is essentially zero, but I'd also give benzos as well. Vomiting is also very common with all these drugs, particularly the more classic hallucinogens. So make sure that you're checking electrolyte panels, if nothing else, if they look sick. Note, everyone does not need labs. You can have a bad trip and someone say, look, it's not because you're having renal failure, it's because you smoke too much pot. Cut that out. And I think an EKG is an absolute requirement for every one of these folks that is really, really sick, okay? If they look sick, they got tied down in leathers at any point, if you had to give them IV medications, you should get an EKG. So scenario one, you got a 22-year-old female. She said, oh, it's kind of a bad trip, very anxious, not really violent, but just really shaken up, not looking good at all. What do you want to do? Yeah, so reassurance, you're going to be okay. Pot's not going to kill you tonight. Don't do drugs. And give them some oral benzos. Observe for a little while. That amount of observation is whatever the patient wants, because they're fine. And send them home with a sober adult. Okay? There's no magic of, you got to watch someone that smoked marijuana for 4 hours. Like, that's garbage. Until they're okay and they've got a sober adult that can take care of them. Get them out of there. Scenario two. So, 24-year-old male with the last name of Zavalos comes in from the dance club. He's tachycardic. That's the move that Eric taught me right there. That is exactly the move. He's very confused. There's no other historians around. You have no idea what's going on. He's just weird. Yeah. So what do you want to do? Get him a pacifier. Yes. What else? Oh, don't remove the puka shells. That's where his life energy is. It's like Iron Man. You take out the battery, his heart will stop. So you get IV access, you give him some normal saline, and you get that full chemistry panel. Since he's hot, you do some external cooling. Any way you want, you just had a lecture on it, okay? And then IV Ativan. Beware of hyponatremia. That's the main thing that's going to get you in trouble with this guy. He's altered, and you don't know if that's because he's high or because he's sick, okay? So you got to separate those out.
You were saying start hot salts, possibly, without even getting labs.
If you didn't have a point-of-care chemistry panel. If you're in the middle of nowhere and it's going to take you an hour to turn around and someone is seizing in front of you and they're 22 and just came from a club, don't wait for the sodium to come back from the lab, because you're going to have really bad brain stuff from that. And the odds of them being hypernatremic, not likely. At our shop, we've got point-of-care chemistries that you can have realistically in the next 10 minutes. So honestly, you're going to get that lab result before the hot salt even gets to the bedside. Okay, so locally, absolutely, you want a point-of-care chemistry panel. But I want you guys to be ready for if you go out in the middle of nowhere and there's a long turnaround for drugs, or for labs rather, and someone comes in as having a seizure like that, I would consider it if it was the right scenario for a young person.
We market like salt pacifiers.
Yes, exactly. That's how you. It also decreases likelihood of them biting their tongue. This is perfect. We'll attach an LMA to it. It's beautiful. All right, scenario 3. A naked young man of unknown age, because turns out if you're naked, you can't carry a wallet. He's found in the street by the cops. And, of course, they said, he's too sick for jail. Let's bring him to the emergency department, like you do. He's fighting and screaming with police. What are you going to do? Anybody? Ketamine, maybe. Put some pants on him. A good man. Yeah, that's the first thing. So he's a danger to himself and others. You could do benzos only IM if he's not that violent. I would actually probably push more towards ketamine, okay? Or go to intubate if needed, okay? And that's an entire gradation. If they're a little bit violent, but you can settle them down and you think you put them in leathers and you walk away, it might just be high dose, IM Versed would be fine. It might be, though, that they need more like ketamine or even to be intubated, okay? Once you decide that decision that you're going to do something like that, you do a full court press for looking out for what's going on. You get all the labs, okay, all the electrolyte stuff. You're going to get tox screens and ethanol levels and all that. Once you have decided that someone was that kind of danger, is not the time to be like, you know what, I don't know if we need an electrolyte panel. He just did drugs. Like, don't do that. You need a full workup. So what about the future of street drugs? So we just talked about where we were previously. where are we going in the future? So N-BOMe is something that's going to ruin our lives in 10 years. So this guy who's doing a PhD paper is like, yeah, I found this thing that's basically 100% serotonin agonist. It's a partial agonist, but it is nearly 100%. And then he published it. And it turns out that some drug addicts really read the literature a lot, and they found out how to make it with really cheap products, okay? So this is going to be something that's going to ruin our lives in 10 years once this becomes more and more popular. It is showing up in America, but it is so incredibly potent because it is much more effective than LSD. It's like a cousin of that. And there have actually been people that have died from it. And honestly, we don't know why they died, because they just took it and then they died, okay? But people dissociate so hard from this that it may actually be inducing seizures and whatnot, and we don't know because people aren't using this in the lab. So designer drugs are becoming more and more common. The pharmacology is incredibly messy. What happens is Congress says, look, you can't make this particular drug, and then a street chemist says, okay, I'll attach a methyl group to it. And so that's what they do. And do they know what's going to happen when they put a methyl group on that? Hell no. They have no idea what's going to happen. And so what do? They sell it, and if people get high, great. And if they don't, well, they try something else, and they put an alkyl group on it or something like that. So that's what we're doing now. And they keep trying to get ahead. The lawmakers are slower than the drug dealers. They will never catch up. No matter how many things that you say are illegal, you know, oh, this brand of bath salt's bad, and you can't do that, and you can't do that. They will find a way to put stuff on it until they make people high. They just will. Okay, that's not necessarily an argument for making them legal. It's just you should be aware that they're constantly on this like cat and mouse game. They're going to stay one step ahead by adding stuff. And they have no idea what this stuff is going to do to people. Zero. Okay, you think we have poor information about like what happens if people do a lot of acid? Well, you're right. We don't have very much information. We have zero information about the stuff that kids are taking nowadays. And then there's the question of designer purity. So they start mixing all this stuff together, okay, including active placebos and whatnot. They just put extra stuff in there that intentionally burns. And it's because it's going to make it so that the person feels like they're going to get higher, okay, because they put some niacin in the pill or whatever. And so that's actually happening. People are mixing things together, and no one knows what's going to happen from that. So even if someone says, yeah, I bought some Molly from a guy, he has no idea if that's MDMA. They could have sold him anything, okay? Because there's no better business bureau for this. Like you can't go complain somewhere if they sold you something bad, okay? And the fact that one of the most potent things ever, N-BOMe, is actually cheaper to make than LSD makes it an incredibly bad combination because it's both cheap and potent. And that's a rarely seen thing in drugs. So, questions? So that's actually a very good point, actually. A lot of these chemicals are actually dermally absorbent. So particularly if they get wet, don't touch wet blotter paper. I know this sounds silly, but it will actually get absorbed through your skin. And so this goes along with the idea of chemical decontamination, that you need to make sure that if there is an unclear substance on someone that you also don't get high from it. So in summary, recognize hallucinogens, okay? All altered mental status is not due to a medical reason, okay? Benzos, and more benzos, okay? Do not be worried about a 22-year-old with a heart rate of 150 having trouble with you giving them a bunch of Ativan. They can handle it, okay? The amount of surge that they have inside their body is enough to kill a horse. You're not going to push them over the edge with some Ativan. Fortunately, most of the time, these aren't old people that you have to worry about some of the respiratory depression and whatnot, but be prepared to manage them, okay? If you keep giving them doses of that, eventually the drug they took wears off, and then they're left with a whole bunch of benzos there. So be prepared to manage the airway, just very unlikely that you'll need to. Get them in a calm environment. Make sure that they're not in a brightly lit room if you can. Dim the lights. Keep it calm. Supportive care, including fluids and electrolytes. A lot of these people are dehydrated because it turns out you don't remember to drink water if you're high for 12 hours. And also hyponatremia is a common side effect of these drugs. And then serial rechecks. This is one of the biggest things I want to emphasize to you. Do not give someone a B52 and walk away from them for 4 hours, okay? I know that is the temptation to do it because you're busy and you got other stuff. You have to check on these people, okay? Because some of these people end up having really bad stuff happen to them, okay? There's nothing protective about doing a bunch of acid that protects you from having an intracranial hemorrhage, okay? Nothing. In fact, these people are the ones that get it because they're so high they can't tell you that they have a headache, and then they often get in traumas because it turns out people that are high and annoying get punched in the face a lot. They also crash cars, and they walk away from them, and you have no idea how they got there. And really, you just know something bad happened and they got brought in by the police, okay? You're not able to figure out what happened to them in the first 5 minutes before you give them all these drugs and put them down. What you can do is keep checking on them to make sure that they're okay. Are their vitals okay? You know, what's happening? If someone's asleep and their heart rate's still 140, something's wrong. You can't just say, oh, that's because they did drugs. Their heart rate is 140. Fix it. Figure out what's happening. But you have to recheck on them. All right. Thanks, guys.